Good evening, everyone, and welcome to Navigating the NDIS in General Practice. I would like to start by doing acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the people of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. A little bit of housekeeping. I'm sure we're all familiar with the side panel we have here. Everyone, all the attendees are muted. Please keep your microphone on mute. Please ask questions via the questions box or raise your hand. Q&A will be held at the end of the presentation. And just so you know, we will be recording the session and only the presentation component of the session will be filmed. Any questions will be edited out of to protect your privacy. So just want to take this time just to talk a little bit about upcoming education training sessions. We have lots, as you can see on that page. We have the Forum for COVID-19 Vaccination Rollout in the infant and NWMPHN region. So that's tomorrow night at 6:30. We have Project Echo series, so cardiovascular disease and type 2 diabetes. That begins on March the 4th. Eyelid functions, lumps and bumps and cancers of the eye. That's March the 10th. Market 101, using digital platforms to grow your practice, March the 16th. We have introduction referral pathway into Mary Health's new chronic pain services on the 29th of March. So all of these sessions and more can be found at our visit. So visit our website. We have an events link and you'll find the events calendar. We also would like to remind everybody that we do have another 2 of these NDIS sessions coming up. So session 2 and 3 will be on the 30th of March and 27th of April. So make sure you flag that in your calendar. So any questions you may not have answered at this session, please make sure you attend the next 2. We also have health pathways. So most clinicians should be familiar with health pathways. We have 750 pathways for GPs to use at point of care. So look, if you want access straight into the platform, you can apply with the Health Pathways team to send your IP address, and then we make it an entrusted IP address at our end, and then it would be nice and easy for you to log in. There are lots of pathways in there that can assist, and you can see all those COVID pathways there at the moment. But a really good platform. Contact your relationship manager if you want a display on how that works. We also have think tanks. So would you like to collaborate in future PHN projects? Do you have specific interests in key areas such as the following here: practice management, human resources, or clinical topics, diabetes, pediatrics, etc.? Come join us, think tank, and be the first to hear the opportunities and get involved with the PHN. Again, visit our brand new web page for more information, or contact your relationship manager. Now, it's time. I'd like to introduce our speaker. We have Emma Gray from the local area. She's a local area coordinator from Brotherhood of St Lawrence. Emma has been working as a local area coordinator for almost 2 years. Emma developed an interest in the area of NDIS access while helping people with psychosocial disability determine why they may not have met NDIS access when they first applied. Emma has supported many people with NDIS access queries, has become an access and evidence champion for her work team, and has delivered presentations focused on access and evidence to many health providers, including AOD and community health services. And tonight we also have Emma's colleagues, Bridie, and I'm going to say it wrong, let me see, Kavana, I think it was, and Julie Ann Robbins. They're both senior local area coordinators from Brotherhood of St Lawrence, Moreland and Darebin Yarra area. Also, they will be assisting with the presentation. So welcome to everyone, and thank you for presenting for us tonight.
Thank you, Yvonne. All right,
Pleasure.
I'll just try and get this going. Hopefully that's working.
There we go. Yep, I can see you.
Fantastic, thank you. Okay, so thank you all for coming along. As Yvonne has said, we're going to be talking about navigating the NDIS in general practice. This is going to be a series of 3 presentations. First one is going to be focusing on the evolution and function of the NDIS and the role of general practice health professionals in navigating the NDIS pathway. So this session is going to be quite broad. In the second session, we're currently planning on doing more of the nitty-gritty access and evidence types of things. I know there's a lot of questions about that. So that is coming up in session 2. And session 3, we're open to ideas, but possibly talking a bit about the independent assessments that I'm sure a lot of you have heard about. So, you know, just keeping in mind that those things are to come. Today is more of a general overview of the NDIS and where health professionals lie in the process, essentially. I'd like to confirm and repeat the acknowledgement of country by acknowledging the traditional custodians of the many lands from which we're meeting today. For me, that is the Wurundjeri people of the Kulin Nation. I pay my respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. Sovereignty was never ceded. This land always was and always will be Aboriginal land. Learning objectives for today. We have, as mentioned earlier, evolution of the disability sector, so evolution of the models of disability, history of disability funding models and how the NDIS came to be in Australia. Then we'll go through the function and primary pillars of the NDIS, how the NDIS interfaces with other mainstream services, including health, how to find information to support patients in relation to the NDIS process, and who can assist you as health professionals to support patients with the NDIS process. Quick disclaimer before we get into it, all information provided in this presentation is accurate as of today, as of March 2nd, 2021, for those who are watching this back on recording. The NDIS is an ever-evolving scheme and changes are being made to ensure that the NDIS is simpler, faster, fairer and more flexible. The most up-to-date information about the NDIS and the processes involved can always be found on the NDIS website, which is www.ndis.gov.au. So, the models of disability. So, in the past, there's been a very what's determined in disability advocacy circles as the medical model of disability. This is essentially treating disability as a health condition, the diagnosis itself, seeing people with disability as abnormal, and seeing the disability as a problem of the individual, something that needs fixing and curing. And it's kind of more focused on what a person cannot do and cannot be. The NDIS has been formed along the lines of the social model of disability, and this is the model that is used by the World Health Organization today. And that is that disability is the result of people living with impairments in an environment filled with physical, attitudinal, communication, and social barriers. So the disability itself comes from the way society treats or fails to support people with disability rather than from the conditions that they have in and of themselves. So the evolution of the NDIS. The previous disability support funding system in Australia was determined by, I've forgotten exactly who now, but it was a commission by inequitable. It was determined to be inequitable and fragmented, underfunded with long waiting lists. It failed to intervene early. It didn't take that into account at all. It was inefficient with weak governance and lacked clear responsibilities. It was found to be disempowering and limiting choice for people with disabilities, as well as devaluing families and carers. funding was not provided on with any kind of evidence base, and it was economically unsustainable and insufficient in allowing future planning and confidence for both people with disabilities and people in Australia as at large who may acquire disabilities, and therefore it did not provide any kind of national insurance. Hence the change to the NDIS. The National Disability Insurance Scheme was designed to fix some of these problems, address the problems, by providing equitable entitlements through national standards. That it had double the funding with ties to Australian government's revenue raising, so the funding has been largely improved. The NDIS takes into account early intervention to minimise long-term costs. This is a really important part of the NDIS and something that we will probably be speaking more to in later sessions. The NDIS was designed to be run to insurance principles and with strong governance to make sure that it was fit for purpose, essentially, and that it would there continued to be safeguards in place. That's still something that, you know, the work on that is ongoing. The NDIS provides choice and control for people with disabilities, designed to take into account support provided and required by families and carers. It is designed to have a research function as part of it, and collecting data and you know, properly having information about people with disabilities in a way that was not possible before. And it's designed to draw on evidence-based practice, stabilising the withdrawal of informal care. There's been, I believe there has been documented evidence of that, of a decrease in carer burden. I don't have the exact stats on that, but I do believe that those studies have been done. The NDIS was also designed to encourage individual plans of participants with focus on long-term care, so that encouraging future goals and, you know, having more of a focus on what a participant can achieve in the future with the right support, rather than just kind of saying, here's some money and let's see what we can do to keep you afloat. The NDIS was also designed to provide full coverage of all Australians for the cost of long-term disability care and support, hence the insurance model. So the NDIS consists of 3 pillars. One is the insurance approach, then we have choice and control, and community and mainstream. The insurance approach essentially ensures that all Australians can have access to the NDIS should they ever need it. The cost of disability supports is shared across the entire community of Australians. Total annual funding is determined by actuarial estimate of supports, and the NDIS modality allows for investing in research and encouraging innovation. The NDIS takes a lifetime approach, investing in people early. Again, that's that early intervention that's so important, such a critical part of the NDIS. And it also allowed the ability to act at the systemic level, as well as funding individual supports. That happens through what's called individual linkage and community supports. And we'll talk a bit more about that later on when we talk about the role of partners in the what's called partners in the community who work with the NDIS. Excuse me. Choice and control. So participants have choice over reasonable and necessary supports and who will deliver them. Participants can determine how much control they want over management of their funding. And a lot of you will know this already, but that essentially consists of choosing whether you want the NDIA, so the agency that runs the NDIS, whether you want them to control the funding with some input from the participant, but mostly just straight through the NDIA. There's also options to have a financial intermediary in place, and there's the option for participants to completely self-manage their NDIS funding. Participants also have flexibility to request a review of their plan if their circumstances change, and this can happen at any point in time. The NDIS takes into account community and mainstream supports and does not replace supports or services which should be provided by others. Where possible, the NDIS can help participants to access those supports or services. So, excuse me, have a bit of water, 1 second. So on that community and mainstream and not replacing supports that already exist, the NDIS interfaces with other systems and other sections of government funding. So the NDIS is responsible for things like home modifications, personal care, development of skills to help a person become more independent. They'll provide allied health and other therapy that's needed because of a person's disability, including occupational therapy, speech therapy, or physiotherapy. These are more kind of maintenance rather than treatment. We'll go into that in a bit more detail in a second. NDIS is responsible for prosthetics and artificial limbs, although surgery remains the responsibility of the health system. Assistive technology, aids such as aids and equipment, such as wheelchairs, adjustable beds, or hearing aids related to a person's disability are also the NDIS's responsibility, as are therapeutic and behavioural supports for people with psychosocial disabilities. So the interface with other systems, obviously we've got the whole host of government systems. So we've got health, mental health, early childhood education and care, child protection and family support, school education, higher education and VET, employment, housing infrastructure, transport, criminal justice and aged care. The idea is that the NDIS does not provide any overlap with any of these systems. It does not replace any of the supports that are provided by these systems. Most salient to this particular audience would be the health and mental health supports, things that are still the responsibility of the health system, even if someone has an NDIS plan and the disability is related to a health or mental health condition. It is still the responsibility of the health system to conduct diagnosis and assessment of health conditions. And this includes cognitive assessments. We get questions about that one quite a lot. So cognitive assessments, depending on the age of the person involved, can sometimes be early childhood education or school of the education department generally, and otherwise is the responsibility of the health system. Yes. Start that sentence again. Another thing that the health department is responsible for is medication, general medical and dental services and treatment, specialist services, hospital care, surgery and rehabilitation. That's inclusive of palliative care, geriatric services, subacute rehabilitation and post-acute services. And the health system is responsible for planning and preparation for return to home after a hospital stay. Even if someone does have an NDIS plan, that's something that also comes up a lot. And general hearing and vision services not related to a person's disability are also still the domain of the health department. Mental health, similarly to health, diagnosis and assessment of mental health conditions is not something the NDIS funds. Clinical care and inpatient treatment and psychogeriatric services are also the domain of the mental health and the health system. That being said, there are some health supports that are available through the NDIS depending on the participant's circumstances. So the NDIS is not intended to replace health or other public services, but will fund a range of disability-related health supports where they are part of the participant's everyday life and result directly from the participant's disability. This can include supports for continence, diabetic management, dysphagia, epilepsy, nutrition, podiatry, respiratory care, and wound and pressure care supports. It's important to note that these are not things that all participants with the NDIS can always get. It really is very dependent on the particular circumstances of the participant, their disability, and their informal supports to some extent. So, reasonable and necessary is a phrase that the NDIS uses a lot. Reasonable and necessary supports refer to the supports included in a participant's plan, which are funded under the NDIS. The National Disability Insurance Agency, the NDIA, fund reasonable and necessary supports that help a participant reach their goals, objectives, and aspirations, and to undertake activities to enable the participant's social and economic participation. We quite often get asked what are some tips for identifying what supports might or might not be reasonable and necessary. I generally like to think of it as there's 6 kind of need to avoid these first before you can even consider whether something is reasonable and necessary. So those 6 things are, and this is outlined in guidelines and legislation. Support must not be likely to cause harm to the participant or pose a risk to others. The support must be directly related to the participant's disability. So if it's not related to the participant's disability, it's not for the NDIS to fund. The support cannot duplicate other supports delivered through alternative funding through the NDIS. The support cannot be related to day-to-day living costs, and this goes for activity costs. So, for example, if you've got a participant who wants to go see a movie with their support worker, participant's ticket cannot be paid for with NDIS money, and neither can the support workers usually. There's a companion card, so that's not an issue, but they also wouldn't be able to have their activity costs covered either, which is why companion cards are a thing. So the other kind of no-nos, obviously, if the support is contrary to Commonwealth, state or territory law, the NDIS is not going to fund that. And NDIS funding can also not consist of any kind of income replacement. As far as the legislative guidance on reasonable and necessary supports, as long as you've met the criteria outlined in the previous slide that I just spoke about, the next things that need to be justified, and all of them need to be justified, are: will the support assist a participant to pursue their goals, objectives, and aspirations? Will the support assist the participant to undertake activities so as to facilitate their social and economic participation? Does the support represent value for money? Is the support effective and beneficial, having regard to current good practice? Does the funding of the support take into account what is reasonable to expect others to provide? And is the support most appropriately funded or provided through the NDIS? So as a bit of an exercise, I've got a bit of a case study example for you. This is something I just made up. This is not someone who exists or based on anyone who exists, just as an extra disclaimer. So Sarah is 53 years old and has met access to the NDIS with listed primary disability of schizophrenia and a secondary disability of a physical impairment. In her case, it's severe osteoarthritis in her right ankle. She and her case manager have asked that the following supports be included in her plan. So which of the supports might she be able to get funded through the NDIS? So I might just give you all maybe about a minute just to quickly look through those and have a quick think, or quick jot down of which ones you think might be funded through the NDIS or not in this particular case. Obviously, lots of information that we might need extra, but you know, just as a first guess, I might just give you a minute.
We should play some thinking music at this point.
For anyone who might have difficulty seeing the screen for whatever reason, the supports that are on the screen at the moment are psychiatrist appointments, psychology or counselling appointments, physiotherapy, occupational therapy, specialised footwear, assistance with cleaning and or gardening, a CPAP for sleep apnea, diabetes supports, transport funding.
Emma, will you give us a hint on how many aren't included and how many are?
I don't think so. I think you can just have a bit of a guess as a starter. All right. Hopefully that's enough time for you to have had a bit of a squeeze through. So I'll just talk through each one of those. So in this particular case, and in fact in all cases, psychiatrist appointments will not be covered by the NDIS. This is still the domain of the mental health system, the health system, and therefore the NDIS cannot assist. Something that comes up a lot is whether NDIS can cover kind of gap fees. We're all aware that there's not that many bulk billing psychiatrists available, and whether people can use their NDIS funding to pay the gap between the Medicare fee and what they actually have to pay. Short answer to that is no, they can't. The NDIS is not, it's not designed to fill in gaps that Medicare may leave, essentially. So next we have psychology or counselling appointments. In Sarah's case, maybe. So if the counselling or psychology appointments are part of mental health treatment, if they are part of standard treatment for schizophrenia, then no, that is still the domain of the health system. However, most people who are able to meet access to the NDIS for a psychosocial disability have already had to prove that standard mental health treatments aren't really working. If they are still, using ongoing counselling as a way to, to manage their mental health symptoms, this is something that, again, they should still be getting through the mental health system. If, as in the case of schizophrenia, and definitely as in the case of, we see it a lot for borderline personality disorder, if the appointments if the appointments, psychology appointments, are based around things like building social skills, better developing kind of behavioral and emotional tolerance, if it's essentially if it is treating the disorder itself, the condition itself, that's the health system. If it's something that is trying to improve the overall, decrease the overall functional impact, on those various life domains, then that's something that the NDIS may be able to fund. Again, that's something that's very individual. The person who is doing the planning meeting with anyone who's met the NDIS will be able to kind of, provide more information on that person's specific circumstances. But yeah, if from the point of view of someone's asking to get on the NDIS because they want to have some extra money available for more psychology appointments, not necessarily something that's actually going to be funded. Next, we have physiotherapy. In Sarah's case, that's probably fine. She's got a physical impairment which is limiting her mobility. Doesn't actually say that, but it's implied that if she's got that on there as a disability, it is impairing her functioning. Yeah, physiotherapy should be fine. Occupational therapy, also fine. It's very rare for someone to not get occupational therapy approved in a plan if they need it. The NDIS loves occupational therapists. Honestly, that's tip number one. If you've ever got anyone applying for the NDIS, if there is any way that they can get some money available, or a chronic health management plan or something to get an occupational therapy functional assessment, that is kind of the unofficial gold standard of evidence for functional impairment as far as the NDIS is concerned. Specialized footwear, yep, fine. Again, that's to do with the functional impairment from the osteoarthritis. Assistance with cleaning and gardening, also fine. That's this, again, fairly standard for someone who either due to the schizophrenia, there's amotivation issues, so they may not be able to get themselves up and going or organized enough to attend to their household cleaning, and or in this case it could be that the mobility is limiting certain elements of her ability to do cleaning or gardening. Now, CPAP, in Sarah's case, no. So unless there's evidence that I'm not aware of, and I'm not a health professional, so if this is a thing, then my apologies in advance. But unless there is some kind of very clear link between the schizophrenia and or the osteoarthritis and the sleep apnea, and I'm talking very clear, not just like sometimes these disorders present together, then maybe it would be considered, but otherwise, in Sarah's case, unlikely. There are cases when a CPAP will be covered by the NDIS, such as, most obvious example that comes to mind are kind of motor disorders, the later stages of neurological disorders, MS and things along that line, motor neuron disease. So, things that have affected the participant's ability to breathe or have resulted in sleep apnea. Those are the types of disability-related health supports that the NDIS can look into funding. Now, diabetes supports, in Sarah's case, maybe. I have seen in my time as an LAC people get diabetes supports funded. Generally, it's because their disability has an impact on their ability to manage their diabetes supports. So if someone is unable due to their schizophrenia or their intellectual disability to properly manage their own diabetes treatment in the same way that other people would be able to, that is something that the NDIS can potentially help with. Usually it'll be training up a support worker to assist with the blood glucose monitoring or insulin injections and other supports that are required. But essentially, there is some wiggle room there as far as the disability-related health supports go. And for Sarah, transport funding, also likely to be a yes. It's, again, like we don't know Sarah's specific circumstances because we haven't spoken to her because she's made up, but it's very likely that with severe osteoarthritis in her right ankle, catching public transport is going to be something that is dangerous for her, that, you know, potentially there's not enough stability, especially peak hour public transport. And it's also very, very common in many of the participants with schizophrenia that I have had communication with, that they are unable to access public transport due to extreme paranoia and or anxiety around being around other people, or, you know, any other number of reasons that the type of disorganized executive function might cause issues with driving or public transport. So I hope that has provided a bit of a quick insight. Obviously, each case is extremely individual. That's one of the beauties of the NDIS, is that it does acknowledge the fact that all participants are separate individuals and they need, you know, individual supports, individualized supports. So yeah, if you have any queries about specific participants, I would highly recommend contacting your nearest LAC office, and again, we will cover that in a minute. Do we want to have a quick thinking break at this point?
What do you think? Do we need a break?
Not sure if silence means yes or no.
Charlotte has said no.
Okay, cool.
So we go with Charlotte.
All right. One response is
enough.
Yep, cool. Let's do it. So, role of partners in the community. So, the Brotherhood of St Lawrence is partnered with the National Disability Insurance Agency to provide local area coordination and early childhood, early intervention services in Hume Moreland, Northeast Melbourne, Bayside Peninsula areas, Western Melbourne, and Brimbank Melton. So I believe we should be the partner organisation for everyone who's attending this particular PHN session. Ooh. There we go. Right, so we don't have any of our early childhood partners with us on the call today, so we are unable to provide a huge amount of information there. It is a slightly different system, but we will have people from early childhood presenting with us at sessions 2 and 3 if you had any specific questions there and wanted to hold on to them for a bit longer. So our early childhood partners provide support for people with disabilities aged 0 to 6. They help families identify a child's goals and support needs. They provide information to help families make decisions about the right supports and services for their child and family. They help to access the most appropriate mainstream and community supports, provide practical strategies and short-term interventions. So people in the early childhood space are all qualified allied health practitioners. So they are able to provide short-term intervention for people who don't quite meet the NDIS criteria for longer-term supports. And for those who do require more long-term early childhood intervention support, support to access an NDIS plan is also something that the ECEI partners will support the family with. Local area coordinators provide support to people with disabilities aged 7 to 65. It's quite well known that local area coordinators, provide assistance with people who are participants of the NDIS or who are trying to become participants of the NDIS. Just a quick side note here, there's quite a lot of confusion between local area coordinators and support coordinators. Support coordinators essentially provide support to people who already have NDIS plans, who have slightly higher needs, and they require someone with a bit more time to properly focus in and help them arrange each of their supports. Local area coordinators are we're a broader role, so we provide, as well as support to people with their NDIS plans, we also conduct the initial planning meetings with many participants. And we also support the NDIS with another element of the National Disability Strategy, which is information linkages and capacity building. So this includes working to build an inclusive community, working with individuals who are not eligible for the NDIS to find appropriate community and mainstream supports, collaborating with community and mainstream services to create greater accessibility and inclusivity of people with disability, and providing support for NDIS and disability-related inquiries. So essentially, anytime you have, simplified, but anytime you have a disability-related or a disability support-related query, feel free to look up the details of your local partner in the community, and one of the LACs or early childhood workers will be able to assist with your query, or at least point you in the right direction. So, role of you guys, role of general practitioners and health professionals is very important in the NDIS, especially in the early stages of people trying to get access to the NDIS. GPs and other health professionals are important in helping patients to understand the NDIS, particularly people who have limited community connections and support outside their GP. There's quite often the case that people who especially come from lower socioeconomic backgrounds haven't had the resources to explore specialists and other community supports, and therefore their GP will often be the primary point of call. GPs and other health professionals also help to refer people to current information on the NDIS website about who can access the NDIS, or if the patient would benefit more from speaking to someone than from trying to find the information on a website, which often the case, you are also more than welcome to refer them to an LAC or ECEI provider in their area. Supporting an NDIS access request is also something that GPs and health professionals are integral in the process. So you'll be completing, and a lot of you will have done this already, I'm sure, completing supporting evidence section of the access request form, which, by the way, has been recently updated. The new access request form is much clearer than the old one, and I would highly recommend finding that on the NDIS website and having a look. GPs and health professionals will be documenting if the access request form doesn't seem like the best option, they will at least be documenting that the person has or is likely to have a permanent disability, and provide copies of reports or assessments relevant to the diagnosis and condition that details the extent of the functional impact of the disability. As I mentioned earlier, this point of what goes in the evidence and who is or is not likely to meet eligibility to the NDIS is currently what we're planning to focus most of session 2 on. If you have any specific questions regarding that or regarding anything else NDIS related, really, there will be a feedback form circulated following this session, I believe. So please do send through any questions you may have so that we can best tailor that next session to your queries. Something that we did want to note is billing for completing an access request form. So when GPs provide any details about a patient without an associated consultation and without the patient present, a Medicare rebate is not payable. However, in providing this information, it is reasonable to expect that GPs will perform an examination of some description to assess or confirm the patient's current medical condition. With this examination, the time taken for GPs to provide details and information for the purposes of the NDIS may be claimed under a Medicare item if it is part of the consultation. Consistent with the operation of the Medicare benefits schedule generally, it is at the GP's discretion to select the Medicare item number that most appropriately reflects the nature of the consultation. In case you're wondering where you can find this sort of information later on, we won't unfortunately be able to provide a copy of the slides because, as mentioned previously, they change, the NDIS changes quite a lot. But the information is always on the NDIS website. This recording will be available to you, and there is actually a specific section of the NDIS website that is specifically for general practitioners and allied health professionals. It can be a little bit tricky to find if you don't know exactly where you're looking for it, but usually if you Google search NDIS GPs and allied health, you'll end up in the right spot. Right, so some quick example scenarios of when you might be required to do NDIS referrals. And again, these are taken from the NDIS's own GP resources on their website. So the parent of a 5-year-old boy who has autism would like support for their son. In this case, you would refer the parent to their local early childhood partner, and you can find the contacts for your local partner on the NDIS website. In the case of most of you, you will be supported by the Brotherhood of St Lawrence, so the numbers for both LAC and ECEI will be on the last slide of this presentation if you wanted to jot those down when we get there. So the early childhood partner will then either link the family with appropriate community and mainstream supports, deliver short-term early intervention supports, or assist the family to complete a formal access request into the NDIS. In the above 6, so the 7 to 65 range, we've got, so if you've got a patient who is 42 years old, who has a permanent disability, who you think will benefit from the NDIS, and they currently do not receive any government support. If the NDIS is available to them, and that is if they are aged less than 65 and meet the residency and disability requirements, and again, we'll go through more of that in the next session. Either you as their health professional, the patient, or their guardian or carer can call the NDIS on 1-800-800-110 and request an access request form. That form is also now available, as I said earlier, on the website. So it's available to download, and it's a fillable form now, so people can do it entirely on their computers if that's what's going to suit them best. The patient will receive an access request form or download it and will be required to fill in the form, including providing evidence of disability. Upon receiving a valid access request, the NDIA must respond within 21 days. If the patient is eligible for the NDIS, they will receive an individual NDIS plan that outlines the short and long-term goals they want to achieve. There's a step in there that is the patient having a conversation with a local area coordinator or an NDIA planner to discuss what's going in that plan. Essentially that's the broader outcome, is that if they're eligible for the NDIS, they will receive supports. If they're not, then the local area coordinator in your area will be able to provide further assistance at that stage. Right, so scenario 3, you have a patient who is aged over 65 and has a permanent disability. What can you do in that case? If the patient is aged 65 years and over, unfortunately they are not eligible to join the NDIS and instead must be referred to the Australian Government's My Aged Care program. More information is available on the My Aged Care website about this. Just to note, because we do get questions about this as well, if someone joined the NDIS before they turned 65, they are able to continue receiving NDIS support. So I do have people on my caseload. For example, I have someone who is 68 because she applied for the NDIS when she was 64. So it is possible for people to stay on the NDIS if those are the supports that are more appropriate to them. The patient will receive a My Aged Care assessment to work out their care needs and what types of care and services they may be eligible for if they're over 65 when they want to apply. After access decision is made, if a person aged 7 to 65 is deemed eligible for the NDIS, an NDIS representative such as a local area coordinator or an NDIA planner will contact the participants to gather information to develop an NDIS plan. NDIS plans are built in accordance with the participants' immediate needs and their medium to longer term goals. If access is not granted, patients can be referred to a local area coordinator partner for assistance with next steps. Persons aged 0 to 6 will be guided through the NDIS access process if necessary with their ECI partner. All right, that's all from me, I believe. Thank you for attending. As mentioned previously, a feedback form will be provided after the session. Please let us know what you'd like to hear from us in the following sessions. We're currently planning, for those who may have joined after I said this the first time, we're currently planning on having session 2 be around the eligibility and who's eligible for the NDIS, what does the access process look like in more detail, and how to provide best case evidence, best practice evidence. And the third session we're hoping will be updates on independent assessments and what's happening with the changes in the NDIS at the moment. So I guess we'll open up to a Q&A at this point.
Thanks, Emma. That was great. Very informative. At the moment, we don't have any questions. So please, everybody, if you have any questions, pop them into the chat. I'm more than happy to read them out, or please unmute yourself and let us know what you're thinking.
And just again, for anyone who might be having who might not be able to see the screen for whatever reason. Currently, the details on screen are the Brotherhood of St Lawrence NDIS details. We've got local area coordination phone number is 1300 BSL NDIS or 1300 275 634. And the email address is ndis.info@bsl.org.au. ECEI contact details 1300 BSL ECEI or 1300 275 323. ECEI.access, so ECEI.access@bsl.org.au.
Okay. Looks like everybody's shy tonight, Emma, and you've given us such an informative session. So I think probably all their questions have been answered. But like Emma
Well, thank
mentioned,
you very much.
Yeah, but I was going to say, like you mentioned, everyone, just remember an evaluation survey will be sent out following this session. So please complete the survey to ensure sessions 2 and 3 cover your areas of interest. So let us know what you want us to talk about. I do have a quick question that's come up. I missed the first half of the session. Is there any possibility to access? Yes, we will have the recording up on our website and links will be sent out in the next week or so. So you can rewatch it and share the recording round to everyone. Looks like we've done great. We finished, I think, 15 minutes early. Record time. I think that's it.
I do often
Last
get
call.
pictures that I talk too quickly, so my apologies if that was the case.
No, I think you've done well. We even had that 1 minute of think time, which I was impressed with, that you held on to the silence. So that is it. I think we called it. Thank you very much, everybody. Thanks, Emma. Thanks, Bridie. Thanks, Julianne. Remember, everyone, come back for session 2 and 3. We will send reminders out. Watch our education page where you'll be able to register. Thank you. Thank you. Good evening, everybody.
Thank you.